women and cancer, the various clinical perspectives and management. So, introduction. So, cancer is the leading cause of death among women globally, affecting both the high income as well as middle income countries. In Indian women, factors attributable towards high risk of cancer are increasing. So, even women constitute more than half of the aging population in the world. So, there are various risk factors that it may include tobacco use, obesity, physical inactivity, shifting reproductive behaviors like delayed childbirth and lower parity. So let it be the lower income countries or the middle income countries, the cancer is on rise. So previously, the cancer types once predominantly was seen in high income countries are now becoming more common in lower as well as middle income countries. So there are various parameters. So coming to the cancer incidence, you can see the percentage of new diagnosed cancers in 2020 among men and women. So most of the cancers, males are have a preponderance. Let it be the brain and nervous system cancers, or especially the esophageal cancers. Males have more incidence. Coming to the females, I think in women, thyroid cancers are on rise, and even gallbladder cancers. You can see from the chart, gallbladder cancer, almost 64.6% women has gallbladder cancers, and around 76.6% of the total thyroid cancers are seen in women. So these are women leading. So other cancers like colon cancers and stomach cancers, women and men are equally have equal incidence. So these are various sex-related differences. Coming to the strong sex-related differences, these are seen in mostly thyroid carcinoma, head and neck squamous cell carcinoma, lung squamous cell carcinoma, adenocarcinoma. The various carcinomas, you can see the stronger relation and the weaker relation. So the cancer shows strong or weak sex-related molecular differences based on various somatic mutations, somatic copy number alterations, DNA methylation, mRNA expression, microRNA expression, and some protein expressions. So among the four women cancers, the burden of female breast cancer is highest globally. So these are the trends. So during the past 30 years, the incidence, death, and daily of female breast cancer kept increasing worldwide. So in most regions, especially developing countries like India, the cervical cancer was the second most women's cancer. At the same time, we have seen increasing trend of both ovarian as well as uterine cancer. And also, you can see the age standardized incidence rates of breast cancer, ovarian cancer, as well as uterine cancer were positively correlated to the socio-demographic index value. So you can see on the right the estimated trends in 2015, 2020, and 2025. Still, the breast cancer is leading, followed by cervical, and next the ovarian cancers. So this is the diagnosis, staging, and the treatment planning. So this is how it goes. So if it's a cancer-directed treatment, then we proceed with that and make sure the patient is cancer-free. If not, we look for the disease progression. Then, if any recurrence, we plan treatment accordingly. So, what are the various symptoms for breast cancer? I think everyone are well aware. It can be in the form of breast lump swelling, thickening, or dimpling, or irritation of the skin, nipple retraction, or any nipple discharges. Especially the reddish color discharge and some skin discoloration. Also, we need to think of malignancies. Coming to the lung and bronchus cancer, they may present as cough, blood in sputum, or hemoptysis, shortness of breath, chest pain, unexplained weight loss, etc. Obviously, colon cancer has symptoms like change in bowel habits, rectal bleeding, abdominal discomfort. These are various symptomatology used in various cancers. I think coming to the colon cancer, the most often we see constipation or diarrhea in certain patients, are followed by abdominal pain, lung cancer, cough, fatigue, dyspnea, etc. The various symptoms and cancers we normally see in women and their typical symptomatology. So coming to the selected US Preventive Service Task Force recommendation for cancer screening of adults at average risk for cancer. So normally we need to screen for breast cancer in females at the age of 40 to 49, and also decision to start the screening mammography should be an individual one. So if normal, we need to repeat mammogram every 2 years. So this is everything are like little flexible depending upon the patient condition and the family issue of malignancies and the symptomatology of the patient. You can decide on how frequently you need to repeat the test and look for any cancer in the certain patients. So with any suspicion of malignancy, a methodological is to look for head to toe physical examination is required to determine the possible site and to delineate the extent of disease. Then you have to focus on the clinical history, should a direct examination with specific focus on identifying the likely area of primary malignancy. So you need to look for which part of the which system is involved, and you might need to localize the part where the malignancy is present. Then you can go for performing lymph node examination, and then you can categorize, go for a biopsy and differentiate whether it's a benign or a malignant one. And also, if the patient is presenting such as other features of other organ system involvement, then you have to think of metastasis, such as any masses at different sites or any bony lesions or any full-fledged jaundice, pleural effusion, septomegaly, any abdominal distension. When we go for ultrasound showing ascites and as well as raised intracranial pressure, especially when there are meds to the brain. So these are various things you need to do for when you are suspecting malignancy. So what are the investigations? So basic investigations are abnormalities in lab findings can indicate the presence of a cancer or the metastasis or some paraneoplastic syndromes. And to anticipate a possible biopsy, order an international normalized ratio test and complete blood count to document platelet counts. Because before going for any procedure, we should make sure to look for the viral markers and the coagulation profile to make sure everything in place. We do not encounter any problems after biopsy. So it is also important to know the baseline creatinine levels who will be undergoing imaging, who require contrast because there are high chances of having contrast-induced nephropathies. So what the basic recommended workup of labs are: go for a CBC, complete blood count, creatinine level, electrolyte levels, calcium, magnesium, and phosphate levels. Also, you need to look for liver function tests, including the albumin level test, the INR ratio, the LDH, the lactate dehydrogenase levels. If indicated, you can also go for serum protein electrophoresis as well as tumor markers in certain group of patients. So there, as we all know, there are various tumor markers, which are the substances produced by either the cancer cell or the host in response to the presence of cancer. So tumor markers range very widely in sensitivity and specificity from different cancers, and we need to look for false positives also. They can be elevated even in benign conditions. So they definitely facilitate diagnosis in order to investigate a specific malignancy or unknown primary tumor, but should not be ordered indiscriminately because we have to look for the cost burden, cost effectiveness, especially the Indian subset of patients. So tumor markers can be useful to follow a known cancer to assess the treatment response or during survivorship care for the disease recurrence. So as we know, the various tumor markers like CA, carcinoma embryonic antigen for colon hepatocellular cancer, CA 19-9 for pancreatic and bile duct cancers, UN5 HIA for neuroendocrine cancers, CA 15-3 for breast cancer, CA 125 for ovarian cancers, alpha fetoprotein for hepatocellular and germ cell tumors, beta hCG for germ cell and gestational trophoblastic tumors, and of course thyroglobulin as a tumor marker in some thyroid malignancies. So this is a very important steps. So of course, after the imaging results will confirm the presence of malignancy, then you have to determine the best site for a biopsy. So unless there is a very high clinical suspicion of cancer, you need to advise the least invasive test with the lowest radiation exposure should be ordered. So coming in breast, if you are suspecting breast cancer, then first go for the diagnostic mammogram and breast ultrasound, as they are non-invasive and the patient also would be comfortable for in undergoing those tests. So and also you need to go for chest X-ray when for initial investigation of suspected thoracic cancers, and if necessary ultrasound. So you need to go for additional imaging, and if there is very high clinical symptom malignancy, CTs can also can be reasonable. And also you need to go for uh, before going for biopsy, you need to go for CT scan if necessary. And also in certain patients you need to follow up with PET scans to know the spread. So biopsies are ideally performed on the most accessible suspected tumor in order to minimize complications. So as we know, we have to look regarding the anticoagulation management before biopsy. Make sure the patient isn't on any antiplatelets or any oral anticoagulants or warfarin or any low molecular weight heparin, etc. So if there are any patients on any anticoagulation therapy, make sure you stop at least 2 to 3 days, then decide how to proceed. So any biopsies that are high risk for bleeding, like the solid organ biopsies, they require anticoagulation be managed appropriately. So as we know, the chemotherapy regimens, which are already fixed and have been evolving through since ages, we've got newer molecules as the previous speaker has discussed regarding. So these are the older therapies using doxorubicin and cyclophosphamide in combination with followed by paclitaxel in breast cancer, and also folinic acid along with oxaliplatin in colon cancer, and also carboplatin along with paclitaxel in ovarian cancer, etc. These are all the chemotherapy regimens. So most anti-cancer agents are administered at standard dosages according to the body weight or the body surface area. So I think which may considerably vary between the men and women. Also, the body surface area has been the guideline, many guidance mention about the body surface area. So because of that only we calculate the doses and give the chemotherapy. So these are also we need to focus upon. Women have a larger distribution volume of lipophilic drugs whereas men have a larger distribution of volume of water soluble drugs. So this also we need to keep in mind, and also men typically tend to have increased activity of cytochrome P1A2, 2D6, and 2E1 enzymes, resulting in increased metabolism of their corresponding drug substrates. While women have higher cytochrome P3A4 activity, which is integrally metabolizing the majority of the drugs. So these things we have to keep in mind before administering the anti-cancer drugs. So as we all know, the pathogenesis and treatment, it is breast cancer is one of the most prevalent tumors in women, and its occurrence is associated with a multitude of factors such as genetic mutations, late menopause, and obesity. And also there are numerous factors which tend to change the progression of breast cancer. So we have to keep in mind both the tumor cell characteristics and the elements within the tumor microenvironment, whether the cellular or non-cellular. So in recent years, there have been significant advancements in the diagnostic technology for breast cancers. So this we all know. So the etiology of breast cancer, of course, apart from the gender, female sex, the age also plays an important. As the age progresses, the risk of breast cancer also would increase. The family history and certain reproductive factors like early age at menarche, later menopause, nulliparity, and first childbirth after 30 years, they all are risk factors. So breastfeeding is independently associated with a reduced risk, with longer duration associated with a greater relative risk reduction. And also, we need to keep in mind the overweight and obesity are associated with increased risk for postmenopausal breast cancer, while the effect on premenopausal breast cancer is not as clear and remains an area of active study. Also, we know overweight and obesity also tend to cause menstrual irregularities in women, causing PCOS or PCOD disease. So, this is a genetic predisposition, the hormonal factors, and various lifestyle factors, especially the radiation exposure, smoking, obesity, and physical inactivity, all are attributable with a significant p values. So globally, breast cancer accounts for roughly one third of all malignancies in women, with its mortality rate constituting about 15%. And the high income countries typically exhibit higher incidence rates than lower and middle income countries. Although mortality rates are often lower due to better access to early detection and treatment. The absolute number of breast cancer cases is increasing in many developing countries due to the population growth as well as the adoption of Western lifestyles. So this is the routine diagnosis of breast cancer involving the imaging, then pathological examination, the clinical and physical examinations. Then, of course, we go to the respective investigations or diagnostics. Then we stage the cancer, and depending upon the stage of cancer, decide the treatment. So this is the approach to breast cancer management. We can see the risk factors, nulliparity, genetic predisposition, cigarette or alcohol exposure to estrogen, late menopause, and obesity. So from the primary side, how it progresses, it can go for distant metastasis to either vertebrae, brain, lung, or liver. And of course, these are various influencing factors: the tumor stemness, the cell senescence, the programmed cell death, intratumoral microbiota, etc. And also, we have got a good treatment options. Uh, I think compared to the traditional method of histopathology, we also go for ultrasound, if necessary, CT, MRI, immunofluorescence, and the digital pathology, etc. We have got various treatment options like going for surgery, radiotherapy, endocrine therapy, immunotherapy, targeted therapy, and chemotherapy. Recently, chemotherapy is very much trending, especially with the monoclonal antibodies. So even also we need to look for the long-term management, like going for a comprehensive rehabilitation plan, and also if necessary for digital health and tele-rehabilitation, psychological as well as social support plays a vital role. And also we have to emphasize regarding the diet and lifestyle intervention in our cancer patients. So there are different targeted therapies in breast cancer. So as you all know, the anti-estrogens, the LHRH analogs, the CDK4 by or K6 inhibitors, so PA3K inhibitor. These are various examples. So they have been depending upon whether the patient is triple negative breast cancer or the ER positive breast cancer, the doctor would decide and how to proceed. So it is basically individualized for every patient. So traditional treatment for breast cancer include the breast conservative surgeries and mastectomy, while the axillary surgeries include the axillary lymph node dissection as well as sentinel lymph node dissection. There are various novel approaches like thermal ablation, cryoablation. Also, we are doing best in certain patients. And also, there is something called NAT neoadjuvant therapy, which eradicates tumor and completely avoids surgery. So these are various consumables and equipment needed for providing breast and cervical cancer early detection tests in primary health centers. So with this basic tests, I think we can detect or we can screen patients And if necessary, you can, if you are suspecting cervical cancer, you can just go for a pap smear, etc. So coming to the endometrial cancer, it's of course malignancy originating within the epithelial lining of uterus. There are different two types. One is the estrogen dependent, second is the non-estrogen dependent. These are the various risk factors. And also, when you are using hormone replacement therapy or the estrogen replacement therapy, make sure you treat adequately and if necessary only. So coming to the International Federation of Gynecology and Obstetric recommends adenocarcinoma with squamous differentiation be graded by the glandular microscopic features. So grade 1 is solid non-granular growth less than or equal to 5%, grade 2 is 6 to 50%, and grade 3 is more than 50%. So assessment begin with a thorough history and physical examination, then consider symptoms, individual risk factors like hypertension, diabetes, asthma, etc. And go check for family cancer and patterns. And also lifestyle, personal lifestyle factors should be documented whether the patient is a smoker or obese and have a reproductive history. So collect a multi-generational family cancer history, and you need to assess for any hereditary syndromes like Lynch syndrome, etc. Refer for genetic counseling when indicated. So, and of course, in endometrial cancer, the most frequent symptom is the abnormal uterine bleeding. It can range from minimal irregular bleeding to postmenopausal bleeding. So, around 10% of postmenopausal bleeding is due to endometrial cancer. So, you need to keep in mind this thing and go proceed accordingly and assess for the risk factors. And also, we need to look for the family history, etc., and do the needful. So, diagnosis is confirmed by histological evaluation of endometrial tissue. Additional tests like labor imaging used for staging and rule out other differentials. So these are the first line laboratory tests and the cytological based endometrial assessment criteria we normally look for. Of course, the transvaginal ultrasound is the first line for postmenopausal bleeding. We look for if endometrial thickness is less than 4 mm, biopsy may be deferred. So otherwise, you can think about it. So and also the the transvaginal ultrasound features suggestion of cancer, the focal thickening or irregular endometrium, heterogeneous endometrial texture, and also some fluid in the endometrial cavity, especially the postmenopausal. And you can also look for any myometrial invasion by any unknown lesion. So you can go for advanced imaging for like CT scan of the chest, abdomen, or pelvis, depending upon the suspicion. And you need to evaluate for metastasis and it could guide the pre-surgical planning. So you can even go for MRI or PET-CT to assess the lymph node involvement. So of course, this should be managed by a team of doctors. It could be including a medical oncologist, a surgical oncologist, or the radiation oncologist, etc. And even you need to address the psychological aspect. That is also very important because many patients after diagnosis of cancer go into depression. So this is also an important spectrum to think. So cervical cancer continues to rank among the top gynecological cancers worldwide. According to current
Dr. Lokesh,
data, 14th, yes,
Dr. Lokesh, please conclude.
yeah. So these are various histories. We need to look for physical examination, screening tools, etc. So this is how we go assessment of this uterine cervical cancer. So definitely early identification relies on vigilance for subtle signs like abnormal bleeding, discharge, etc. We need to risk stratify, diagnose. We need to prevention and we need to screen. Prevention and screening are the cornerstones, including HPV vaccination, cervical cytology, risk-based genetic testing, as well as counseling, especially for those with hereditary syndromes or reproductive risk factors. So these are the various most common cancers we see in women. Okay, they need to be addressed as soon as possible to avoid their progression so that we save the women. Thank you everyone for your patient listening. Any questions are welcome. Thank you.